have with us a pioneer in complex transplants, Dr. Deepesh from PGIMER, Chandigarh. He brings us insights into donation after circulatory death, but growing but underutilized pathway in India. Dr. Kanwar is Professor of Renal Transplant Surgery at Postgraduate Institute of Medical Education and Research in Chandigarh and a leading figure in kidney and pancreas transplantation in India. We welcome you to present your topic.
Thank you very much, Noto, for having me. I'll be presenting on donation after cardiac death and some considerations on how we can expand the donor pool by using this pathway of getting organs for donation. So I'm going to cover the importance of DCD, the types of DCD and how the basic outline of how DCD is done. What are the outcomes of DCD and the PGI experience that we've had, and what we might expect in the future with DCD, and what challenges we might expect in India if we try to expand the DCD path for organ retrieval. So I don't think I need to go into a lot of detail because it's already been covered and repeated ad nauseam in so many transplant meetings. That transplant is the gold standard for treating organ failure economically, medically, and quality of life outcomes, which greatly outweigh any other treatment option that you might look into. And the need for transplants is great as demand far outstrips supply, not just in India, but all over the world, even in countries which have fairly advanced transplant programs. I think maybe just a handful of countries which are actually able to have reasonable wait times waiting for a transplant. So just a handful of countries are actually able to fulfill their need for organs. If you look at the name category of donors, the types of donors that we have, so we've got live donors, and basically you're limited to kidneys and livers when you come to large organs, because donors need to live afterwards as much as the recipients. And the conundrum of transplant is you're giving a functioning organ to replace a failing organ. So obviously you need someone who doesn't need those organs anymore. And there is still a lot of debate on what kind of deal do the live donors get out of this when you're looking at young live donors who might have to live the rest of their life, maybe 30, 40, 50 years with a single kidney. And there's a lot of data that a nephron mass definitely affects your life afterwards. Like if you have a decrease in nephron mass, then what happens to donors afterwards? So obviously, if you would need many organs, for example, pancreas, intestine, heart, lungs, and composite tissues like hand transplants or face, you're going to look at deceased donors. And we've got two types: that donation after brain death and donation after cardiac or circulatory death. So I'm going to refer to them as DVD and as DCD. Obviously, like I said, deceased donor organ transplantation is ideal. And for most of the world, donation after brain death is a major contributor for these organs. Why? It's because there's been a long and sustained interest in brain death as a diagnosis in itself. And that has resulted in, like what Pandit said, quite a set process wherein you diagnose brain death. And because you might look at legislation and you might look at regulations as probably something difficult to fulfill, but these are also protected in the sense that once you have these regulations and you have these rules in place, you have a set process of saying this is somebody who is brain dead and we have fulfilled these criteria. It's very easy then to have a viewpoint that you stand on and say that these are the patients that we can actually ask for organs. Also, brain death donation overall is a much easier process than donation after cardiac death, especially because you've got time as compared to donation after cardiac death, because the latter entails a rapid onset of organ ischemia. So if you have organ ischemia and you have to move really fast, which is logistically an issue. And if you want to counteract that, then you need a special setup as compared to somewhere like you can diagnose a brain death donation in the ICU and have time to prepare your recipients. Historically also, the reason why DCD is on the back foot is, paradoxically, the first deceased donor organ transplants were from DCD donors. And when these were tried early in the 20th century, transplantation itself was in a very nascent stage with very poor outcomes. We did not know much about tissue typing, about the immune response to transplantation, or even something so simple and fundamental now as the cooling of the organs. And by luck, by chance, fortune has favored DBD donation, because about the same time when brain death certification processes were put in place is about the time when transplantation matured as a science and we had reasonably good outcomes, which made the DBD transplants the de facto method for diagnosing brain death, for diagnosing death for donors. If you look at DCD, then potentially lethal ischemia is the thing that you're looking to manage. It's a race against time when you're looking at DCD donation, whether you're doing controlled or uncontrolled. So if you have cessation of circulation, there is immediate onset of organ ischemia, organs die rapidly, and either you'll have to call off the transplantation, or else if you go ahead with such suboptimal outcome organs, then recipient outcomes are sometimes pretty bad, and you might sometimes think you're better off not doing, you might have been better off not doing such transplant. Ischemia times wise, DCD donations tend to have the longest ischemia times, significantly more than live donors, who have a somewhat a longer ischemia time as compared to DVD donors, who basically have, if you're done properly, basically you're going to look at a zero warm ischemia time. And warm ischemia time is where you lose a lot of the organ viability when you're doing these transplants. And roughly, I don't know whether there's any way to measure, but 15 minutes of cold ischemia time equals to 15 minutes to half an hour of cold ischemia time equals to 1 minute of warm ischemia time. So that's the kind of damage, ischemic damage that you're looking after. The classification of donation after cardiac death is actually based on the preparedness of the retrieval team to counteract the ischemia of circulatory arrest. So there's a Maastricht classification of donation after cardiac death, which was initially had classes 1 to 4. So class 1 and class 2 are uncontrolled DCDs because you have no idea of what has happened before and even during the retrieval. So class 1 is dead on arrival to the emergency services, and class 2 is patient has come to the emergency services, had a cardiac arrest in the emergency services, and then was not able to be resuscitated. Class 3 is controlled DCD that we will look into just shortly. So this is an orderly withdrawal of life support with a ready retrieval team. And this is the kind of DCD that you're looking at if you want to get good organs. Class 4 is a cardiac arrest in a patient who's already in brain death, whether you've diagnosed before or during the, already diagnosed or during the diagnosis of brain death. And depending upon your setup, you can have varying degrees of control. So in some cases, you might have reasonably good control of your ischemia timeline, and sometimes it can be totally uncontrolled. And class 5 is an unexpected cardiac arrest in the hospital, and this is also mostly uncontrolled. Class 5 was added later on because some programs were able to carry this out. So how is controlled DCD done? And paradoxically, for DCD, the first prerequisite is a non-survivable massive brain injury, not to the level of brain death. And you have continued pulmonary and circulatory functions which are dependent upon medical intervention to continue. And these are likely to stop if these interventions are withdrawn. So once your family has to agree with the treating unit on the futility of continuing medical treatment in such cases, they agree for withdrawal of life support, and counseling and communication with the family is essential if you want to go ahead this way. This is most often carried out in or in close proximity to the OR to have to shift a donor using an elevator or a lift and long hospital corridors to reach the OR, often you will have poor outcomes in DCD. Once in or near the OR, then you have monitoring of respiratory, circulatory, and oxygen status while life support such as ventilators and inotropes are withdrawn. And then over a period of time, circulation and oxygenation will decline and in asystole after a variable period. So this period is the agonal period. So during this time, organs can sustain ischemia if your saturation. So you might have some degree of cardiac activity going on. You might have a pulse palpable, but if you have a saturation less than 70% or your mean arterial pressure less than 50 millimeters mercury, you'll have to take a call whether you're going to continue with the process or not, because this is your functional warm ischemia. So you have some degree of cardiac activity, but not enough to sustain the metabolic needs of the organ. And typically, you'll find transplant teams, transplant programs accept maybe 30 minutes to 1 hour of functional warm ischemia time before the call of the effort. Also, sometimes you can have a pretty long period. You might have to wait a long period for asystole to happen. So often there'll be set time limits depending upon what protocol which country is following. So you might have up to 3 hours of period in which you'll wait for asystole to happen. If it does not, then you might have to call off. Most of them, they'll call off the effort or the transplant effort. Some programs will allow interventions to optimize organ retrieval, for example, placement of perfusion catheters or maybe heparinization. But there's been a lot of debate on this because people have tried ethically also on ethical grounds to ensure that the number of interventions which contribute or may potentially contribute to dying should be limited as much as possible. So that was controlled DCD. Uncontrolled DCDs are definitely more fraught with problems. First is obviously logistics. Most of the times these are far from the OR, and there's likelihood of significant ischemia prior to or during the retrieval in such circumstances during the transportation, and also because of the hurried nature of the retrieval. And because it is rushed, it may be traumatic to bystanders, even to the team which is participating in the retrieval. And though there are some centers, depending upon cultural milieu, where controlled DCD is not existent or well developed. So there are many ethical questions as to what level of intervention should be done when retrieving organs for an uncontrolled DCD. Do you perform chest compressions, or what degree of the CPR protocol will you undertake to perform or to maintain organ perfusion? And what happens if this results in return of spontaneous circulation? How long do you wait then afterwards? Depending upon, because DCD has been such a topic in which people might have such differing takes, there have been quite a difference in how DCD has been implemented worldwide. So it has been increasingly contributing to the deceased donor organ transplantation, and significant proportions, up to 30 to 40% of all donations in countries such as UK, Spain, Holland, Belgium, Russia, Australia, and the USA. Up to 30 to 40% the organs come from donation after cardiac death. So approaches are different. Like I mentioned, controlled DCD is quite common in the UK, Australia, and USA. And uncontrolled DCD is somewhat more common in Spain and France, depending upon how comfortable they are with withdrawal of life support as end-of-life care. In India, we are not legally allowed to withdraw life support, so controlled DCD is out of the question for now. So there has been some progress from the judicial side and some progress from professional bodies, for example, the critical care fraternity, on withdrawal of life support and advanced directives and do not resuscitate. And also there's a desire to recognize and optimize end of life. So what are the outcomes of DCD? So organs that have been utilized after DCD: kidneys and livers in the thousands, pancreas and lungs in the hundreds, and hearts less than 100 or so, less than 50 actually. But these are the organs which are commonly utilized after DCD. The DCDs have the potential to have much poorer outcomes as compared to DBD because, like I mentioned before, ischemia is a much more inherent part of DCD as compared to DBD. On the other hand, this is offset by a stricter selection of criteria for donors and recipients as compared to DBD. And with this worldwide, the results, published results appear to be acceptable and comparable to DBD. So what's the future of DBD? Because you've got good outcomes, and countries like UK, US, Australia, Spain are reporting that DCD is contributing more and more to the deceased donor organ transplantation. Is obviously DCD is likely to increase because neuroprotective care is becoming better, and you have a lower percentage of patients now progressing to brain death. Some brain death is now preventable. Whether they can completely come back is a different question. There's also been improvement in traffic accident fatalities, better traffic, self-driving cars, and better compliance with personal safety requirements when handling vehicles. And there's also awareness and acceptance of the futility of excessive medical intervention in critically ill patients. So this awareness coming not just among family members, but also in the medical critical care fraternity itself. And obviously, advanced directives are becoming more and more common of the level of intervention that people will accept to be done on them when they themselves are critically ill. There's also a host of evolutionary changes in the organ transplantation itself, especially with regard to organ procurement and preservation. Newer technologies or new ways of doing things, for example, regional hypothermia, normothermic machine perfusion, or hypothermic oxygenated perfusion, and viability assessment, vitrification of organs, which allow us to not only take organs which have had some degree of or variable degree of ischemia, but also to assess whether these organs are fit for transplantation or not. And this is a projection that has been done, is that less than 10% of patients with brain trauma will have an easily diagnosable brain death, and up to 25% of deaths now happen in ICUs. So up to 90% of this, so 1 out of every 4 patients approximately, you might have to take some decision to have a limitation of what is the level of care that you'll be giving, whether you'll be able to bring them back to life as it is. So what's been our experience with DCD? So our first patient with DCD was in 2011, when we had a lady with interstitial lung disease, and she had a cardiac arrest in the ICU, was shifted to the OT, and we had a warm ischemia of 70 minutes. So like I said, logistics is a big part of DCD. So one kidney never functioned, and the second had a suboptimal function, lasted for just about I think 2, maybe 3 years or so. 2014, we had to declare graft loss for the second recipient. So that experience led us to realize that it's not possible to keep organs within this limit of 60 minutes of warm ischemia. And we have to have some degree of organ preservation, organ perfusion during this period. And we decided then that we'll be continuing external cardiac massage in those patients. And we had considered prior cannulation for regional perfusion, but then we defaulted to using what we call the DBTL, the double balloon, triple lumen catheters, or else when that was not available, to go for a rapid cannulation when retrieving these organs. Over the next few years, we had refinement of our experience, and this is one example that where we had much better outcomes than what we started with. So, a 22-year-old potentially brain dead donor, family considered for organ donation, could not be declared brain dead because sodium remained high at 180, 170. And in those days, I think 2013, 2014, when we were starting our program, our intensivists required some time to get up to speed with how to manage a brain dead donor. So nowadays it's much easier, but in those days it was difficult. And this donor had a cardiac arrest. Our recipients were already ready. So after cardiac arrest, the team decided, the ICU team advised us that they'll be continuing external cardiac massage for a total of 65 minutes, a total warm ischemia of 80 minutes. And then one of our 2 recipients backed out, saying that they were not willing for this transplantation. The one recipient who went ahead with the transplant with a single kidney after 5 years had a creatinine of 1.03. So that's a reasonably good outcome that you can stand up and say, yeah, this is a good outcome that we've had from DCD. So between 2011 and 2018, we had 14 donors where we had kidneys retrieved after cardiac arrest. So 6 patients of them were refused brain death certification because of high sodium or issues with achieving high enough PCO2 during apnea testing. 4 had cardiac arrest after first evaluation by brain death by the committee. 3 had cardiac arrest after brain death was certified. And the last patient is the patient that I had presented as being our first patient in 2011. External cardiac massage was used in all donors except the first 2 or 3. So this was done manually in 3 patients, in 3 donors, and we had an automatic external cardiac massage machine applied to 8 of them. So the time for external cardiac massage was between 20 to 40 minutes, and a total warm ischemia time ranging from 50 to 90 minutes. Only one patient, like I said, we considered bedside cannulation, so with a double balloon, and that was done for one donor. For 5 of them donors, we prefer to do an intra-op double balloon triple lumen catheter insertion. So these are the outcomes that we had. So we had 24 recipients out of 14 donors. The mean age of the recipients was 42 years. The mean age of the donors was 32 years. And we had pretty good output on day 1 in some of these patients, but all of them have had a really good serum creatinine, mainly because we were strict in our selection. So recent experiences, again, from 2018 to 2024, we had no DCD donations. And our recent experience, again, in 2025, just this year, we had one pancreas kidney DCD who the donor had cardiac arrest while they were preparing to retrieve organs from a DBD. So this patient now has a stable graft function of insulin, euglycemic on oral hypoglycemic agents, so low dose oral hypoglycemic agents. The serum creatinine of 1.3 at 3 months post-transplant. And 2 kidneys we got from a patient who had a cardiac arrest while preparing for brain death certificate. This donor had cardiac arrest 3 times, was resuscitated 2 of those times, and the 3rd time could not be resuscitated, was taken up for retrieval. Rapid cannulation was done. The first patient was discharged on post of the 21, and the second patient was discharged on post of the 44. That's a 2 hours difference in cold ischemia time, and you had prolonged DGF in the second patient. So I think this highlights what the degree of ischemic damage that these organs can have. But both of these patients are having a serum creatinine of less than 1.1 at 2 months post-transplantation. So there have been other centers who have published their experience. IKDRC Gujarat, Dr. Vivek Pote Center have published between January 1999 and January 2012. So they've also had a significant number of DCD, and these are the outcomes of with a 10-year survival of 67%, which is pretty good. DGF they observed in 36, and this is similar to the figures that we had. So is there a PGI model for DCD organ retrievals? And maybe, and I say maybe because we are used to this kind of retrieval, and whether that is a widely adoptable model is something which centers have to decide on their own, whether they're able to put in the kind of resources and the logistics that are required to develop an uncontrolled DCD program. So the PGI experience, people often ask us how we do our DCD, and we are at pains to point out that this is a target of opportunity. The external cardiac massage that we do is in response to the exigencies of the situation, that is to maintain organ perfusion while the OT was being made available. And this is not CPR. We're not working to resuscitate donor. We readily acknowledge that we have a set of unique local factors which allows UDCD to be done, uncontrolled DCD to be done. And that is, as a team, we're dedicated to transplant only, and we have a long-established DBD transplant program. Like I said, all our DCDs are the byproduct of a DBD which failed to mature. So we used, and we expect to use, only kidneys for now. We have not gone to other organs like the liver, and we might explore the pancreas sometime, but in the future. But we are for now only kidneys. We are very selective in which donors we felt could undergo UDCD, the uncontrolled DCD. The donor mean age of just 32 years points out that we have the strictness of our selection for the donors. The same thing for the recipients. We look for recipients who will be able to sustain a significantly prolonged period of DGF. We have had very supportive administration, especially our coordinators and the hospital administration. Police also in and around our center are very sensitized to deceased organ donation. So, like I mentioned, from between 2020 to 2018 to 2024, actually, we've had no more uncontrolled DCD donations because our ICU became that proficient in maintaining the brain dead donors. So you will have, if you have good ICUs, the number of DCDs should actually be relatively low if you're looking at uncontrolled DCDs. If you have a really good ICU, you must be, you would expect to be in a setup going for a controlled rather than an uncontrolled DCD like we had. So conjectures on DCD in India, look, what can we surmise about the DCD donation situation in India? People are working hard for it. There have been position papers put out both by transplant teams as well as by transplant professionals as well as professionals in the ICU, the critical care side of things. And we would like MASTEC 3 to be the standard, but more, I think none of them actually were. Till now, the legal framework has made withdrawal of life support treatment quite cumbersome. And we believe, as a transplant professional, I believe that DCD should be a side effect of good end-of-life care and of withdrawal of life support. So MASTEC 4 and MASTEC 5 is usually chaotic. They're in the gray zone between controlled and uncontrolled DCD, and you might miss out some organs. But these are relatively low-hanging fruit for established DBD teams. If you have an established DBD program, you expect that your transplant team is well versed with relatively rapid retrievals, and you have some of these patients who do go into cardiac arrest. Sometimes you'll get a warning that this patient has had maybe 1 or 2 prior arrests, have been resuscitated, and then will at one time go for an uncontrolled DCD. I think MASTEC 3 is a much simpler and better way to do things. It is unambiguous, well organized, well defined. Time points are there for the ischemic damage that you will accept. And it is established in the West. There's a large body of literature that supports it. So there are a lot of challenges in India, but the most important thing, it seems to be inertia now. I might go on and say what are the challenges of uncontrolled DCD. Like I said, logistics is difficult. Ischemia times difficult to cut short, and often retrieval teams need to be very well versed with what they're doing, and you might have to have them on for long standby, waiting for sometimes an uncontrolled DCD to happen, and you're constrained to use an in-hospital donor organ. The challenges for controlled DCD really seems to be one is that there is no end-of-life care in India practice as such. LAMA is so commonly practiced in India, and I feel the main thing which stops us from going to controlled DCD is the inertia, both in terms of what we expect the legal aspects to be, and what we find in the medical community, the reluctance of physicians to offer families end-of-life options, to say that, yes, this is how much we've done, no more is possible. Would you consider taking off futile medical interventions? This is my last message, is that DCD transplant, if we did at PGI, I think anyone can do it. We are not a very special team in terms of ability, or what has helped us is that our team leaders have been very proactive and willing to do sometimes difficult things also. Thank you. Thank you very much for your patient listening and for the opportunity presented by Noto.
Thank you so much, sir. Your explanation of the donation after circulatory death falls under your experience at legal institutes of the country, eliminated a lesson and a powerful opportunity to widen. So we thank you for your insightful talk.